See if we have a quorum.
Bryan,
Here.
Polk, Blackwell, Blunt, Kaufman, DeBar, Doty, Fillingame, Frazier, Harkins, Hobson, Horn, Jackson, Johnson, McMahon, Parker, Parks, Wiggins, Witherspoon. We have a quorum.
What sort of quorum? Is it a good one, bad one, in between? Thank you. I would say, sort of in reverse order, there's been a lot of attention to a bill concerning pharmacy benefit groups, and I've asked Senator Polk and others who I think have been contacted to sort of meet and see what sort of recommendation they might have about how to proceed on this, whether there's any modification to the House bill that might be possible or what. And I think I understood you were getting your group together after this. Talk to them. Alerted them to this. They know who they are. They know who they are. So that bill will come before the committee. I don't know when, but it will be on the calendar. There is an item on the calendar today, 1520. People have asked to speak to the committee about that. So I would ask the proponents of this bill and the opponents of the bill to sort of get together. I'd sure like to have each presentation like about 5 minutes long. I think committee members may or may not have questions, but I'm willing for the committee, I think it would help the committee to hear a little bit about the bill, but it would help us to hear a little bit, not everything about the bill. We need to know a little bit about what we're doing. We don't have to know everything about what we're doing. But if we could have brief presentations and not get involved in something that goes on for a long period of time, that would help. But I would ask the proponents and the opponents to sort of get together and figure out who's going to talk and for how long. Turning to the agenda, House Bill 868 simply extends the repealer in existing law. House intended to extend the repealer to 2025. There were two places in the bill where they left the number 2023 instead of changing it to 2025. So just for procedural purposes, I think we would do well, if the committee thinks well of it, to adopt the proposed amendment just to get the bill before us in proper order. There's a motion to adopt the proposed committee amendment, which changes the year in two places. All in favor say aye.
Aye.
Opposed? The ayes have it. This bill extends the repealer in existing law of the Patient's Right to Informed Healthcare Choices Act until 2025. So are there questions or debate about the bill? Senator Fillingame.
Thank you, Mr. Chairman, for an amendment at the proper time.
Go right ahead.
I would like to propose that the Board of Optometry be able to perform background checks on their optometrists. I think that's in Section 10.
Say that again slowly. I can't hear with this mask on.
I would propose that the Board of Optometry be able to perform background checks on their members, on the optometrists.
Okay. Do you know where that goes in the
Yes,
bill?
sir. I believe that would be in Section 10 of the bill.
Or more important, do the staff attorneys know where it goes?
That would be more important.
Does anyone have a question about the amendment as far as what the amendment does? Okay, is there any debate on the amendment?
686.
Senator Fillingame, do you have anything to say on behalf of your amendment?
I would just say that most of the other boards are able to perform background checks on the members that they're supposed to oversee, and optometrists, the Board of Optometry can't do that. So we're just trying to get them to where most of the other professional medical boards are.
Are you ready to vote on that amendment? All in favor of Senator Fillingame's amendment say aye. Aye. Opposed, no. The ayes appear to have it. The ayes have it. Anything else? I suppose we should do a strike all. I think it'll be easier on the floor since we have two amendments. So Senator Polk moves title sufficient, do pass, strike all. Ready to vote? All in favor say aye.
Aye.
Opposed, no. The ayes appear to have it. The ayes have it. House Bill 688 is the Pharmacy Practice Act. This also extends the repealer to 2025. Bill also makes, I believe, some stylistic changes. Long title mentions minor non-substantive grammatical corrections. I've looked through the bill and I can't find any snakes in there. They're minor changes. Debate, ready to vote. Motion title sufficient do pass on House Bill 688. All in favor say aye. Aye. Opposed, no. The ayes appear to have it. The ayes have it. House Bill 777 is a clarifying bill. The bill doesn't purport to do much of anything, and I don't think it does. It clears up some vague language in existing law. Existing law says that the fees for licensed professional counselors shall be $200, and they can increase 10% a year. And the bill before you just says there'll be $220. I understand that's the current amount. So that would remove the language that says the fees can go up 10% a year. There are some questions about CLE or whatever, and I think this just makes questions. I looked, I didn't find a snake. Not one there. Motion's title sufficient, do pass. All in favor say aye. Aye. Opposed, no. The ayes appear to have it. The ayes have it. House Bill 984 says that the Board of Nursing may have a special meeting if notice of the time and place has been given by the executive director to all members of the board. The existing law requires a 10-day advance notice. It's a bit difficult to have a special called meeting, which by its very nature is something you need to meet and tend to in a hurry, if you have to give a 10-day notice to all the members. So this would just, what I think is probably the way most boards operate, that says that you can have a special called meeting if all the board members get notice. Motion title sufficient do pass. Debate? All in favor say aye. Aye. Opposed, no. The ayes appear to have it. The ayes have it, and we'll report that to the Committee on Accountability, Efficiency, and Transparency. Now we're at House Bill 1520, which is the hospital bill. Is Ms. Clay here? Mrs. Clay? There you are. You know, nobody can hear with these masks on. Do you have someone who wishes to speak in opposition to this? Sure. If you want to speak to us in opposition of the bill, you're welcome to do that. You're welcome to come up to the podium. If you could get to the evils of the bill in 3 or 4 minutes, that would be much appreciated.
Yes, sir. Thank you,
Why don't
Mr.
you just
Chairman.
introduce yourself and tell us your interest in all of that.
Yes. Thank you, Mr. Chairman and committee members. My name is Dr. Dan Edney from Vicksburg, and I have served in primary care practice for almost 29 years there, but more importantly, I've served as a hospice medical director for about 25 years in Vicksburg. And I am one of your board members on the Mississippi State Board of Medical Licensure, so I have a unique perspective on these issues. And you have before you an effort at legislative intervention regarding a board regulation that was promulgated this year after our board's leadership last year thoughtfully listened to the concerns of legislative leadership about the time that you were confirming me to go on the board. So I got dropped on the board about the time all this was stirring up, and I want to reassure you that as a hospice medical director, your concerns have been thoughtfully considered and applied into the existing policy. Your board, in taking those concerns seriously, had several open hearings, listening to concerns from specialty societies, primary care, hospice agencies and directors, practicing physicians, and other regulatory agencies such as DEA and the MBN. And we thoughtfully considered all those. And those comments and concerns went the whole range of, don't put any regulations on us to you need to be heavily regulating the issue of prescribing for hospice. Listening to all those concerns and working through many committee meetings and board meetings and writing policy, editing policy, clarifying policy, rewriting policy over a year, we now have in place what we think is good, thoughtful policy that has been in place since earlier this year. And as a medical director for hospice, I have been in compliance with this regulation without any difficulty, even before it came out. And we had a few points that we wanted to make sure that you understood from your Board of Medical Licensure. That, first of all, we are responding to complaints. We are a complaint-driven agency. We are not out looking for new problems to try to solve. We've had steady complaints from multiple sources, including family physicians concerned about prescribing on their patients, family physicians who didn't know their patients were in hospice, family physicians who were upset that their patients were being discharged from hospice back to them, and now they had to prescribe all the high-dose opioids and benzodiazepines. We've had complaints from family members and patients and pharmacists and across the board, and we feel that those complaints are substantial and appropriate to be dealt with and not to be ignored. Want to point out that our policy 2640 on controlled substances prescribing has nothing to do with hospice. The new rules and regs for prescribing related to the opioid epidemic specifically exempts hospice from all of those rules and regs. And with that in mind, your board wants to affirm the fact that we see hospice care in Mississippi as a critical part of the healthcare continuum, and we applaud our physicians who are serving in that role and those who are serving on those teams, and we fully support the interdisciplinary team approach to hospice and in no way want to interfere with that. But we also affirm the right and the need for patients in the most vulnerable stage being the end of life, that they have a right and a need to have a physician that they know and that their families know and that the physician knows them and knows the family. We don't believe that occurs, and I can tell you it doesn't occur when I review the intake information to see if admission is appropriate. It comes from a clinical evaluation between a doctor and a patient. We also affirm the right and need of patients to have immediate access to palliative care in terms of access to immediate admission to hospice and immediate access to the medications necessary to alleviate their pain and suffering. Nothing in this new regulation in any way inhibits the immediate access to hospice care or to hospice prescribing. And we also affirm the need to make this process as easy and unburdensome as possible on those physicians who are serving in this role. And in that light, you have before you the regulation, which basically sets out a few tenets. One, physicians may prescribe immediately and provide whatever care they deem necessary. As soon as the physician knows that there is an issue, he or she can prescribe immediately without any hindrance from this regulation. But They must evaluate the patient and may choose what manner that evaluation will occur, and that can be an in-office evaluation, which a lot of them are. If they're homebound, then it can be a home visit, or it can be at the physician's discretion, sending a mid-level provider, APRN, or physician assistant to do the evaluation in the home. Or what I do a lot is a telemedicine visit where I'm connecting with the patient and their family from my office in real time, and they have a chance to see me and ask me questions, and I have a chance to, quote, eyeball the patient, which is clinically very significant. We require that that evaluation occur within 30 days from the beginning of prescribing, not admission, but when the first controlled substance is prescribed, then the clock starts and they have 30 days to accomplish this evaluation. The evaluation will be at the discretion of the hospice physician, however they see fit to do it. We just believe that a hospice patient deserves a physician evaluation from the physician that's going to be part of leading the team, as I do and my partner does, and that when we talk about Miss So-and-so, I know what she looks like. I've talked to her family. I spend at least 10 minutes of my time in my office listening to their concerns so that I can lead the interdisciplinary team appropriately. Understanding this, we don't really see the need for this legislation. In no way do the rules and regs prohibit physicians from immediately prescribing. It does not require a face-to-face evaluation if they choose not to do so. And we have taken great lengths to address the concerns brought to us last year and all the concerns brought to us, so that at the point when we had final promulgation, there were no official comments filed, and we went through OLRC process without any difficulty, and we've been up live for several months without any issues. Certainly no issues from my practice or my agency. We have information we'd like to leave with you. Very happy to answer any questions or concerns that you may have.
Do members of the committee have questions? Senator Witherspoon.
Yes, sir. Thank you, Mr. Chairman, and thank you also for being here. I guess I wanted to ask, your agency, the license, of medical license, you and the hospice, there was no conclusion that you all can come up with.
Yes, ma'am. The regulation that we have before you, we felt was generally accepted by all the comments from all the parties, both sides being heard. We brought together the most thoughtful policy that we could see to address the concerns from a regulatory issue, a legal issue in terms of prescribing, and patient safety issues with the needs of hospice and how hospice physicians work. We're trying to make that balance.
Okay, so why are we here with this piece of legislation?
That's a very good question, madam.
Other questions? Senator Parker.
I'll kind of follow up with what Senator Witherspoon was saying there. You know, and forgive me, because all of us have been dealing with different things over the last few months.
Yes, sir.
So this is kind of new, kind of bring this back to our memory and that kind of thing. But my understanding, the regulation that you're changing has been in place for how long? I've got one report.
February.
Okay, that's a new one.
Right.
And then I was also told that there was an agreement last year to hold off on putting that regulation in place until a compromise was reached. So were there any conversations, you know, with legislators or other members to try to reach a compromise that would make both sides happy that got us to this point this year? Were any of those held last year?
Yes, sir, Senator. If you remember where, again, I came on to the licensure board in April when y'all kind of sent that product back and said, try again. That product is extremely what's before you today. We've gone from fairly firm, rigid requirements of face-to-face evaluations much quicker than this to now allowing options on the evaluation. Never do we say you have to see the patient, but the patient has to be evaluated clinically, not just pieces of paper, but the patient before you're going to prescribe oxycodone and fentanyl and Ativan and Xanax. There are legal requirements through the DEA that even supersede us, and we heard from DEA and NBN, and I think we need to listen to their concerns as well in terms of issues with diversion and inappropriate prescribing, even with hospice. And as a hospice director, I can tell you there is a standard of care for prescribing. Just because our rules and regs don't apply to hospice doesn't mean there's not a standard of care in how you prescribe to hospice patients. And physicians like myself need to be held accountable in how we prescribe and how we take care of patients and how we lead hospice teams. The vast majority are doing it right. They're doing a good job. We have no complaints. They're taking good care of their patients. But the complaints we hear are substantial, and I don't think you want us to ignore those complaints.
The personal example that was shared with me by a member of the legislature was a member of the legislature had a close family member battling cancer. And that close family member one night on a Saturday could not swallow. And so some provisions through the system as it is in place were taken that allowed that family member to be seen by, I believe, a nurse, and in collaboration, a morphine type of drop was given that was able to alleviate that throat pain. And that person went home and died just a few days later, which is what hospice is. And so hospice, for me, when one of my patients moves to hospice, I kind of consider, I'm probably not going to be going and doing their care for glaucoma or other things in their home because that's just not what we typically do. But I take provisions to make sure that I collaborate with whoever is managing that care during that 6-month period of life. And I guess my big concern on this, having heard this from a member of the legislature, is that we're not doing something here that is first and foremost not putting the interest of the patient first.
Correct.
Because as the spouse of someone who's battling cancer right now, I want to know that in that instance that things can be done to provide care in a hurry and there not be a need for some type of interaction that is going to cause harm to that person.
Yes, sir.
And so as I look at it today, I'm not sure. Again, I started my narrative, and I'm going to finish with a question. I promise I'm going to get a question here.
Okay.
But I just want to be sure that the people in that desperate need who have this, are not having to have someone come to their house to meet with them. They're probably, so this past week I've had a home health nurse come to my home, and we didn't have a good experience with it, but I do think that gives me a perspective that's a little bit different to kind of at least comment on this. And I just want to be sure that best care is being provided and the speed and in particular the expedience is being addressed. So do you see anything in the new regulation you've passed that would create a hospice nurse in the system to have some concern that issue might be raised?
That's a great question, Senator. And I want to reassure everybody, as I stated, it is the intent of the Licensure Board not to interfere with the immediate access to hospice care and hospice medications as thoughtfully provided by a prescribing physician. That happens all the time. I'll get a call at 10 o'clock at night. We have a new admission. We need what we call a comfort pack, which has several medications to alleviate pain and suffering, and I approve it based on the nurse's evaluation in the field, and then I have 48 hours to approve an emergency prescription of the pharmacy. And in terms of the Licensure Board, if it's a new admission, I have 30 days to do the evaluation how I choose to do it. With me, it's probably going to be a telemedicine visit, but it may be sometimes like doing house calls. Some work. We have an APRN on our treatment team, and she makes a lot of home visits. We have a semi-retired physician that's a family medicine doc who does a great job with our home visits, loves doing them. So it's our choice. And as the physician leading the team, I decide how that evaluation needs to happen, but I'm also responsible for making sure it happens. And when that happens, then I know the patient so much better. It's very hard to defend the position that a patient does not deserve a physician evaluation, in my opinion.
Okay, and I just,
And you have 30 days to make it
Right.
happen.
from my perspective, I'm not sure because coming into this meeting, I'm getting different information, and so, I look forward to hearing the perspective, Mr. Chairman, of
Mr. Senator,
the other side.
you've got the hard copy of the regulation there to
Right.
review.
I think we're gonna have, Mr. Chairman, someone speak from the other point of view if someone is here, so look forward to hearing their opinion about it. Thank you for answering my question.
Thank you.
Senator Blackwell.
Thank you, Mr. Chairman. Thank you, Doctor, for being here today to answer our questions.
Yes, sir.
I just have a few for you. People who are, I guess, assigned to hospice or terminally ill, are they not?
They're supposed to be, yes, sir.
And generally with a 6-month longevity expectation.
That's correct. That's the expectation.
So I would imagine most of these people being referred by a primary care physician, probably for the most part, is that correct?
Or oncology, yes, sir.
Or oncology. And so I would imagine a good number are already on medications, would they not be?
Many of them are, yes, sir.
And what's the, using hospital terms, the length of stay in your experience for the patients you've got within the hospice program?
Well, and that's one problem that we've run into is that if a patient, and there are patients that are there that do not have malignancies. They have a terminal condition, and it's more difficult to judge how long they're going to live, like terminal heart failure or emphysema. And the doctor thinks they're going to live less than 6 months. They may live 2.5 years. And as they approach that 2-year window, then Medicare does not want them to remain on hospice. And that's been an issue of those patients being discharged alive back to primary care, but on high-dose medicines that they need. That's not the issue. But no longer is the hospice director prescribing them. Now it's a family medicine doctor who's their primary having to take that on. And many were uncomfortable because they were never involved in the process of hospice to start with. So these rules and regs try to address that. Specifically, every agency has a different length of stay. I mean, it should be under a year. It's supposed to be less than 6 months, but, hospice doctors aren't God. They can't exactly predict. They do the best they can.
Sure.
And so going along is not even a problem. You can't have somebody on hospice forever.
And most of these patients, are they probably just on palliative care?
No, sir. Being on hospice does not mean you stop medical care. It means you stop heroic interventions, but we still treat their diabetes, hypertension, emphysema, although they have pancreatic cancer. So we don't just stop. Now, at the very end, when they're truly their prognosis is grave, then we start pulling things off, just as there's no need for, and we just focus on their pain. But a patient may be in hospice for 6 or 8 months that needs other medical treatment, and many times their primaries are involved in that part, and the hospice director is managing the pain and the palliative issues. Getting to your point of already being on medicine, that's very helpful, but if I'm taking that role on and now I'm prescribing, legally my prescriptive ability depends on me satisfying the federal government's requirements for my DEA license. That involves, according to the DEA, that involves a patient evaluation.
I'm just a little concerned about the 30-day period of evaluation.
Yes, sir.
I've in my past, I've had some experience with hospice, and most of the physicians who were treating the patients did not want to give up the patient to hospice. They wanted to continue to try therapies, and by the time the patient did come to hospice, I think we had probably an average length of stay of about maybe 13 days. And so that's why I asked what your length of stay was in your experience, or patients
That's a
being
wonderful
did-
point. What if the patient dies before the 30 days?
Right.
The patient satisfied the requirements. But if if the patient dies at 45 days and there's no evaluation, then they don't. But it's not the physician's fault that the patient died before the evaluation was done.
And I'm not putting any fault on the physician. It's,
No, yes,
you know,
sir.
just it's the disease process that goes
Right.
through. But, all right, thank you, sir.
Thank you.
Mr. Chairman.
Anyone else? Thank you very much.
Thank y'all so much.
For coming. We appreciate your taking the time. I know you could be other places doing other things. Thank you. Representative Curry, did you want to speak? Are there others in support of the bill that want to speak? Have y'all come to any, well, that's what they all say. We've heard that before. But are you going to speak, and is someone else going to speak? Have y'all worked out any?
I'm really not in charge of this. I think somebody else is going to speak. They're saying yes.
Well,
Would you like them to
okay.
go first?
Sure, just go right ahead, but we sort of need to keep the time equal on both sides. But thank you for walking down. It's always happy to have you. You know, you have floor privileges. You have floor privileges.
Thank you.
But you're the lead author of the bill, so you could tell us a little bit about your bill.
Thank you. And just for let you know what I do, I've been a home health and hospice nurse for 25 years. I graduated, I hate to admit this, in 1979. 1974, hospice was brought into America, and it's been running fine ever since. And when a patient is given a diagnosis of 6 months or less to live, I will tell you that it is a very private and personal decision to say that I want to die at home with my family, that I don't want to be in an institution, that I want to be my last days spent with my family. There are two physicians that are involved in this process. It is the referring physician and the medical director. So there are physicians that make these referrals. You cannot get a referral from anyone other than a physician. There's no malice here. There are nurses and doctors and priests and social workers and CNAs that go in every day to these patients' home for $140 a day, some more, some less. It's different in different areas. But I will tell you that they chose the least expensive care instead of thousands of dollars a day in an institution. Where I work, I need you to know, and I'm glad you said the 15 days. I looked before I came in here, and our average stay is 14 days. And when a physician refers a patient who has got 6 months or less to live, and yes, we're not in charge, God is in charge of that. A lot of times their condition changes, and I wish it changed from 9 to 5, Monday through Friday, but it rarely does. The legislator, and I'll be glad to share that with you, Representative Mark Baker shared this with us last year. His brother was at home dying of cancer, and he had uncontrollable pain. And at 2 o'clock in the morning on a Saturday night, he ended up with the nurse at the pharmacy because his brother was unable to swallow, to get drops. And he said that it was a moving experience, that he went and got this drop. He put a couple of drops in his brother's mouth, and he settled back down. But under these regulations, we're not allowed to do that. We're not going to be allowed to do that. You know, if your regular average stay is 14 days and you have 30 days to have a face-to-face, I'm not going to be able to change his medicine on Saturday night at 2 o'clock. It's just important that they made the decision to die at home with their family and that we are able to take care of the patient. I just can't stress this enough. Our choices are that I'm going to have to load that patient up in an ambulance and drag them to the ER instead of being able to go to the pharmacy to get that medicine that patient needs. I understand all of this came up during a time where they said it was an opioid crisis, and yes, we've had one. I'm not saying we didn't, but it was not from hospice patients that are dying. I can tell you that every hospice agency since then has policy and protocol that we sit down with the family after the patient has deceased, and we say, this medicine, we need to get rid of it. We need to destroy it because we don't want anybody to get it. 99.9% of our patients, and most all hospice patients, the family is fine with that. You're going to have the 0.1% that says, well, I'm not throwing anything of mama's away, or who knows, you know, maybe they wanted it. I can't control, and we can't legislate morality on that 1%. But I can tell you, to take away the ability for us to take care of these patients who are dying will be a travesty. I work for a very large company. We will be able to absorb that cost, but your little small mom and pop hospice agencies are not going to be able to afford the cost of a doctor going out face to face. They're not going to be able to pay it, and they're going to shut down. Telemedicine would be a great idea if we had rural broadband, but guess what? We don't. In most places in a lot of places that I go, we don't have cell service. I go way out in the country. So it's worked for all of these years. We don't need to reinvent the wheel. Just let hospice companies, doctors, nurses, priests, all of these people that are involved in this case, let us just take care of these patients. Thank you.
Thank you. And there's someone else, I think, who wishes to speak in favor of the bill.
And I'll be glad to answer any questions if you need me to.
Why don't we hear from the other person, and then if there are questions, they can be directed to either of you. Again, I know we're sort of short on time, but we do want to hear from you.
Afternoon. Senator Bryan, thank you. Dr. Bill Grantham, I'm president of the Mississippi Academy of Family Physicians, and we're here today to support this bill after being asked by many of our physicians who are hospice medical directors. This has been a tough issue over the last several years. There are, I believe, some unintended consequences that are being seen already because of this, the regulations. Not that they weren't necessarily well intended in some regard. We tried to bring some of these concerns up for the regulatory commission before the regulations were passed, and that was December, I believe. So I wanted you to hear also from a hospice medical director that has experienced already and has seen some of these concerns. Understand, this morning I was on a phone call with a number of family physicians who share some of these same concerns. We understand this is serious business, this is legislation, but we feel that when this bill was out there, that it would be in the best interest of our physician members who try to provide care to those in the neediest time. We want to be certain that that regulations don't make it prohibitive for the family physicians in rural Mississippi to be able to do this. Dr. Dustin Gentry.
My name is Dr. Dustin Gentry. I have a family medicine practice in Louisville, Mississippi. Hospice is not the only thing that I do. You know, I take care of COVID patients, and I have a clinic practice, a hospital practice, and I work the ER. Hospice is not something I do to make money. I'm not here for political gain or monetary gains, certainly. It's something I do as a service to my patients who, like Representative Curry said, wish to die at home. That is a very personal and sacred decision that they make. I do want to thank the Chairman for allowing me to speak today. I certainly want to extend my utmost respect to the Mississippi Board of Medical Licensure and those leaders at the MSMA. I just believe that there's a disconnect between those that are making these regulations and those that are practicing in the trenches in rural communities. You know, when we talk about telemedicine, since I have really learned how difficult that is since the COVID pandemic has hit. and CMS has relaxed those guidelines. We're doing a lot of virtual visits. Some of you may have done those with your physician. But, you know, I have people that live in Bevel Hill and the Panhandle and all these little communities around Winston County and Attala County and Tibahaw County, and they don't have internet. You can't even send a nurse out there with FaceTime. It just doesn't work. In these small communities, you're going to have roadblocks to care, and that's the last thing that your constituents need, because your constituents are my patients, and I care very deeply about them. And I know everybody does, and we just want to make sure that we're not doing a disservice to some of the most vulnerable patients in this state. House Bill 1520 allows the medical director to do what we've already been doing, practicing responsible, safe medicine in a team setting to take care of dying patients, people that you know, people that are your family members. I will point out just briefly that this bill, if we pass it, it will allow us as medical directors to continue practicing by federal guidelines without added stipulations. Okay, so there are a couple things that as doctors we have to abide by. One of those is the Uniform Controlled Substances Act, and we do have a handout that you can get later. But that act says that it has to have an in-person evaluation to be a valid prescription, and it has to that practitioner can be anyone who's otherwise permitted to administer a controlled substance in the course of professional practice. That's a nurse. And if that nurse works really closely with the physician. I know all of my hospice nurses, I don't have to see the patient screaming in pain or gasping for air to know that I need to make an adjustment to their medicine. I have a good relationship with that nurse, and we can work that out for the best interest of the patient. I'll give you a real quick example. Just before this regulation passed, I had a hospice referral for a dying patient from one of the big hospitals downtown. The patient was sent home and comfortable, but when they got home, they had no pain medications. So the hospice nurse called me, and I did the right thing for the patient. I provided the care that they needed. The patient died a few days later, but I had no idea at the time how long the patient would live. They might live 31 days or 28 days or 60 days or 3 months. I had no idea about that. Then there's one other thing I wanted to set your minds at ease about. I've heard from some of you about diversion, and diversion is the use of pain medication by someone other than the consumer or who it was prescribed to. That's a major concern. I can tell you that I spoke personally with multiple coroners today, specifically the president of the Coroners Association for the state of Mississippi. And her name is Sharon Stewart. She gave me permission to quote her. She assured me that there was no coroner that she knew of that was not disposing of the medication, controlled medications, at the scene with a witness. On those calls where they actually don't go, the hospice nurses, especially the ones that I work with, that's common practice in the industry. They're disposing of it in the home in an appropriate manner with a witness. So the concerns about diversion really are minimal, and we always have our antennas up for that. I think it's happened one time, and we dealt with it appropriately in the time that I've been a hospice medical director. I just ask that you consider this bill, HB 1520, and think about those dying patients in rural Mississippi, because in Mississippi we've got different needs and different circumstances than everybody else in the country. And so your job as senators and legislators is to tailor what is best for the patients in Mississippi. I thank you for your time. If you have any questions, I'll be happy to answer.
We appreciate your coming. Do members of the committee have questions for either of the doctors, Representative Curry? I don't see any questions. Thank you both for coming. I know that you had other places that you could be and other things you could do. The bill before us is essentially lines 8 through 14, which says that the medical director of a licensed hospice may prescribe controlled substances without having a face-to-face visit with the patient before issuing the prescription. The other section, just as a confirmatory section, the legislation has a one-year repealer. So that's the bill that's before us. Is there debate? Well, I'm sorry. I think we've moved on. I'm sorry. We just have limited time. That's the bill. Are there? There's a motion title sufficient to pass. Is there debate? Are you ready to vote? All in favor say aye.
Aye.
Opposed, no.
No.
It appears the ayes have it. The ayes have it. We'll report that to the Senate. Thank you for coming. I'm sorry we just don't have time for everything, but I appreciate your coming. Tomorrow we will meet. We will have a presentation from Bob Anderson, who is the new head of the Department of Human Services. I would say also there was a discussion of the mom and pop hospices. I was not aware that mom and pop had gone into the hospice business. I knew about the grocery stores. Several years ago, Buddy Medlin made us aware that mom and pop had gone into liquor store business. He was here on behalf of the mom and pop liquor stores. Now I hear mom and pop are in the hospice business. Mom and pop are just turning into a conglomerate. Thank you for coming. We'll rise and report.